just keep with us, please.
Now it gives me the honor to introduce Professor Joe Simpson, Professor of Human and Molecular Genetics, Professor of Obstetrics and Gynecology at Florida International University. He will address us about IVF and embryo biopsy for adult onset genes for cancer susceptibility and cardiac arrhythmias.
Okay. Yeah, but this is, advance it with this one right there. Okay. Yeah, okay. Thank you very much. I'd like to thank the organizers of this spectacular annual event, the 30th right now. I've been in several. I always learn a lot, and it's exciting to meet colleagues from globally around the world who are pursuing this. As a geneticist as well as an OBGYN physician, I'm especially impressed by how much genetics has crept into practically every talk as it relates to gynecological disorders. So we're seeing great progress, and that was just illustrated by the preceding talk. So the title is obvious: in vitro fertilization and embryo biopsy for adult onset genes, namely cancer susceptibility and cardiac. And we're going to focus on cancer for that particular purpose. Let's see. Here are the disclosures for my colleague, Dr. Rashitsky, who is the CEO of Reproductive Genetic Innovations, and I am the clinical director interpreting the biopsies for the genetic basis for which the patient had come to see us. So this group has been involved for decades. Here's the spectrum, and I show this to you. It's based upon 2 years ago, and that was deliberate because in 2 years ago, you can look at the number of Mendelian disorders, pre-implantation genetic testing that we pursued, and it's about 10,000. But I want you to look down at each of these stratified area, and you can see that most of these were not adult onset disorders. And so what's going to happen now, moving forward in the future, is we're going to see a lot more adult onset disorders, and in particular, screening for heritable cancers of adult onset. And so that's clearly different. You can look at the numbers as well in terms of what needs to be done. So overall, there is a changing dynamics of pre-implantation genetic testing. The first case was done in 1991. It was fairly slow for quite a while as we tried to figure out who was at risk sufficient to justify that. So there are changing dynamics. But the key thing I want you to remember as obstetrician gynecologist is the first bullet. So the main reason we were doing PGT for monogenic conditions, single gene disorders, was the recurrence, and the recurrence had occurred in families in which there was a childhood onset condition. So we're now moving away from strictly pediatric-based ascertainments to adult-based ascertainments, and I'll go over that in a modest amount of detail. So originally we were looking at pediatric recurrence risk that we were trying to avoid for a given family and certain cytogenetic disorders. Now, if you scroll down, we've got new toys to play with. We've got expanded carrier screening, which is huge. We've got the ability of using gene panels, which are effective and can tell us a precise disorder for a cardiac arrhythmia, or in our case, for cancer. Now, skipping quickly ahead from decades of carrier screening in which we had only a limited number of options, usually a dozen or so, now, at this time, vendors, and I'll show you examples of that, are screening about 400 to 500 different disorders. So a huge number. So screening is not difficult, and it's really not that expensive in terms of carrier screening programs. But the question really is who's going to counsel and who's going to interpret the results for the patients who decide that they want to do it, sometimes over the counter. The American College of Medical Genetics Your battery is running low, it says. So I think that would be IT probably needs to come up and give us a battery that works. But at any rate, so the American College of Medical Genetics decided it would do something differently. We would still look at the same number of 415 disorders that's up there. But on the other hand, they decided we're not going to screen for this unless it's a serious condition that needs to be done and has a relatively high carrier frequency. So this screen is not advancing. IT? See if you can at least delete the screen that's going to prevent people from reading what's on the slide. Right there. Is it going to stay that way? Right here? Good. Okay. So in addition to what the vendors are doing for their 450 condition, this is what the American College of Medical Genetics decided to do. We're only going to screen for relatively high frequencies of carriers, 1 in 200 here, and we're going to decide also within a variety of different ancestral groups, and you can read that number, African Americans, Jewish, and non-Finnish Europeans, which are different from the rest of Europe or so. So in addition, we expanded and expected a relatively severe phenotype. So this is what the results were. No need to go over all the details, but in red is the total 113 genes. Not included in this list, but it's going to be important in the next term, in which you have tier 4 genes, which are 1 in 1,000, and that especially is relevant for the Middle East countries in which there's a high rate of consanguinity. So here's the next step here, moving forward from the original 2021 paper to 2023 just recently, and you can look at their Finnish, Amish, and the Middle Eastern population. So it's possible, easily possible, to screen in that population as well using more stringent issues. Now, one of the things that's occurred when you have expanded carrier screening is that you're identifying individuals that you did not think were at risk. And a good example of that is in ataxia telangiectasia. Pediatricians have been screening for that disorder for decades because a kid who has homozygous ataxia telangiectasia has problems. But the mother was typically not expecting a problem. And she's a carrier, but it turns out if she's a carrier for ataxia telangiectasia or Fanconi's anemia, she's at risk for cancer. So she's unexpectedly an index case that needs to be forward for that. Now, one of the things that has occurred as a result of expanded carrier screening is that most of the patients for which we do pre-implantation genetic testing for single gene disorders are ascertained by expanded carrier screening. So as recently as 2015, you can look at the numbers there. 1/3 of the cases that we did were due to carrier screening programs. But look what's happened in 2021, 2025. So now it's unusual to have a couple that's had a previously affected child. And usually in these particular cases, it's because they've undergone carrier screening, worried about pediatricians, but in fact, they could be at risk themselves. Now, this is the increase in cases that we've had in the last several years. You see for the several decades until perhaps, 2021, 2022, 2012, I'm sorry, you had relatively low numbers per year, but now it's jumping up. And once we get the 2024 number, it's going to be higher yet. It'll be off the screen here. So a lot of movement in this particular area. Just to show you the examples of the cases that we had in reproductive genetic innovations, we're looking at 60 genes, about 829 patients that's there. they usually undergo 2 cycles to have sufficient cases in order to transfer and decide after you've done a biopsy of the blastocyst. But the bottom line is about 1,600, 1,800 embryos that were transferred, 871 deliveries, as you can read, and 733 babies. So about 90% of the babies that are born are single transfers. And so it's the ideal in terms of what we expect. So now overall, looking back at the issues, IVF and pre-implantation genetic testing after a blastocyst biopsy can select embryos for the conditions that are shown in the bullets here: cancer susceptibility mutations, cardiac mutations, especially arrhythmias, which are a frequent cause of sudden death that's not expected. Athletes, for example, are candidates for this, and neurodegenerative. Given the limitations in time, I'm going to just focus on the cancer susceptibility gene because that's, I think, the most common for our specialty here. Now, let me go back. Now, a few words about the etiology of cancer susceptibility genes. It's different than Marfan syndrome and lots of other autosomal dominant conditions like neurofibromatosis, because if you're likely to have a high rate of these cancers, you will have been born with a germline mutation. You inherited it, didn't have any choice in the matter. But you may or may not develop clinical cancer, and you may develop it if there's a second hit or a second mutation, in either the same tissue that the first one had occurred, but remember, it's present in every cell in the body. So that's a very important thing to remember and to use in counseling to the patients. It explains this graph right here. This shows you BRCA1 and BRCA2, the most common heritable forms of genetic cancer. And so let's take the first column, the ones that's quite low, quite small, 7% in the general population if you exclude genetic conditions, but 87% if you live to age 70. So you don't always get the cancer, but you have a pretty good chance that you could get the cancer. And it's a little less for ovarian cancer, but look to the right portion of the slide and you see where the money is, so to speak. So you have not only breast cancer, but the next bar is prostate cancer with a 20% risk, and following that, pancreatic cancer for 7% risk. So both the female and the male offspring are at risk, which comes, of course, as quite a surprise to patients who receive this information. So now, why do we know that there's an increased risk and there's something that one could be looking at? And the key thing now is that gene panels exist. So you seem these days to get a gene panel for almost everything. But the one that we're looking at now, and I'm going to show you in just a minute, is cancer susceptibility genes. And the same thing for cardiac arrhythmias. And this afternoon, I'm going to talk about DNA repair genes, for which there are also gene panels that you can order. So here's an example from Aubrey Genetics, of 91 different genes that are susceptible to cancer. Many of these, there are different mutations in that particular gene. So the number of mutations that could lead to cancer is really quite high, and we don't need to go over the details of that, but it's good molecular genetics. You don't simply look at the exons, you look at the 5' and the 3' regions, because that's where you have enhancers in the population that increases the risk to go forward. You have the same thing for arrhythmias, but I'm not going to talk about that. But it's the same principles. Whatever I say for cancer is going to be related to this condition as well. So now, why am I presenting the case in this way? And the reason is that now we change the clinical management. All of us have had grandmothers and relatives, 2 or 3 generations above us who've gotten in a form of cancer, and we are regretful for that. We do the best we can to help them. You know, we make sure they have the best oncologist around. But now we have to do more. It used to be we just looked at the index case and were treated by oncologists, cardiologists, and, you know, sometimes our colleagues in the room ourselves. But now other people need to be involved for the reasons I'll show you in just a minute. Gynecologists, of course, geneticists, genetic counselors, they've got to be involved. Why do they have to be involved? Because there's a pretty good chance after you've looked at the gene panels that you're going to find this is an autosomal dominant gene that's adult onset, say a 50, 55 or 60-year-old grandmother in our family. Why does it matter? It's matter because she's got a dominant gene. Whenever you've got an autosomal dominant condition, you know, 50% likelihood that every given offspring, that is every one of her children, you know, have inherited that. Not everybody, but 50%. Bad news. And that means that there's a 50% risk there. And as you just move forward, 25% risk for secondary relative overall, unless the offspring has it, in which case it's going to be 50% risk again. So what do you do in terms of counseling? That's the last portion of what I'm going to be talking about. So the counseling needs to take advantage of what we've just said. The first thing you're going to ask here is, do you have any offspring? You know, and have they completed their own family? And the answer is that depends on the next step. So if they have not completed the family, you start from scratch and say, each of your children, 2, 3, 4, are going to be at 50% risk. So let's find out so we can move forward in giving them options, and I'll tell you what the options are in just a minute. If the reproduction is completed, they've already had their family, let's say they're in their mid-40s by now, and the mother was 70 years of age. In that particular situation, what you're worried about is the grandchildren, because you still need to test the offspring, and if they have the disorder, then you need to test the children of that offspring, grandparents or so. And key things is the last bullet. If there's a mutation in BRCA1 and 2, both male and female offspring are affected. So this is totally different than it used to be historically when you may have taken care of patients who need an amniocentesis. So what are the options? 2 choices. I have been doing counseling patients for decades, and until relatively recently, it was usually said, well, you can get pregnant and we can do an amniocentesis. That's no longer the best approach. And people are learning that that's not the best approach. And so now you can undergo in vitro fertilization. We've talked about that the entire meeting here. And you do an embryo biopsy and you decide which embryos are going to be transferred. So you can avoid transferring what used to be a blinded guess, you know, an embryo to achieve pregnancy and avoid any of the offspring being at increased risk. So amniocentesis or CVS, of course, carry the potential for pregnancy termination, and people are smarter than that now. They look up in Google, they see their genes, they want to know whether or not grandmother has a specific genes. Now, final 2 or 3 slides here. How complicated is it? Well, it's not simple, but it's doable, and you should not be frightened about the fact that it would have to be done. So here are the diagnostic pitfalls in pre-implantation genetic testing, specifically as we've talked about now. The amplification of the genes and alleles that you're testing is tough because you've only got 3 to 5 cells, so there's a tiny amount of DNA, and it's not 100% amplification. So it's okay if you just have a marker chromosome, but on the other hand, if that's the mutant allele that you're trying to detect, you're in trouble. So you need to do that. So what we do in that particular case, and I'll show you an example next, is that we look to see whether or not the mutation was there and should have been, and if so, we adapt to that. So let's take oops, it's hard to see. Let's take this particular case right here. So the bottom line here has got lots of red marks, and that's the markers and the mutation. You can see the mutation right in the middle for cancer. That's it. That's what you're looking for and not transfer. And the black markers and normal in obviously tell us that we don't need to worry about that. Now, suppose you go up at the top and you've got embryos 2, 4, 5. They can be transferred. And what happens to embryo 3? Well, you really don't know. You can see red marks and you can see black marks, but you are not indicating, you're not finding the mutant gene as you would see at number 1, 6, 8, 9 as an example. You can see that mutant gene, so you don't know whether it's there or not. And so the best thing in that particular case is to do look at the markers, 127, 118, 104, for example, and if they're there, but there's nothing in terms of the mutation just didn't amplify. And you can't stop there because we will transfer an embryo that would not have been good. Final slide that I want to take home for you is that what happens if you look at BRCA1 and BRCA2. So these are our experiences up to about a year ago. So in BRCA1, 94 of 193 embryos that we did a biopsy and analyzed were due to a single mutation, 187 deletion of A and G. So that's about half. But all the rest were almost unique. Usually there was one, occasionally 2 or 3 families that had the same mutation. So what I'm saying here is that it's not difficult to screen for all of this, but on the other hand, this is difficult. So this is not minor league molecular genetics. You are looking at 99 plus 1 different mutations, and so you've got to screen the entire thing. Same thing for BRCA2 in that particular case, 69, a different mutation, 6174 deletion of T, and all the rest were unique to a family. So I think I'm getting the signal that we need to end this, and we do. So here are the key things I've tried to go over. Expanded carrier screening identifies lots of couples at risk, many more than what we had, including those at the Middle East. Cancer susceptibility and cardiac arrhythmias now can be transmitted to offspring. It's adult onset disorder. No longer think that it's not. Robust technology exists to handle the complications of the molecular analysis. It should not be something that we worry about if you're a practicing clinician here, but you need a group that is well vested in terms of doing that. And finally, I think the greatest movement here is that if you have a couple at increased risk, they can choose IVF, whether they're fertile or not. Because the point is, do we need a cohort of embryos that we could test by blastocyst biopsy and decide on that basis which embryos to transfer and which ones not to transfer. So I'd like to thank you for the opportunity of being here. Always a great meeting.